Thank you for joining us. Today, we'll be discussing healthcare transformation, the shift from volume to value, and specifically, finding the upside opportunities so that healthcare organizations can survive the sea of change under the Affordable Health Care Act. We're now to our open question and answer, and we have a question that I'll address to Kim. One of our audience members asked, do you see risk and quality taking on more active roles on the revenue side of healthcare? If so, and how?
And the answer is yes. And because doing the right thing, doing it well, ultimately will impact your revenue. So a model in which doesn't separate those things out, I think, is a more efficient model. Finance working on reducing costs in its own world and in a vacuum, and quality working on outcomes, and risk working on, managing events and reducing risk is not a sustainable model. You have to bring people together, and they have to understand the impact of what they're doing and what they're proposing needs to get done in terms of clinical care, the delivery, the management of all of that. So I really think that having a mind to cost, quality, and service as really that mantra around value, reducing waste is then really where we're going to end up, I think, making a more significant impact.
Thank you for those comments, because quality and risk often are siloed, and in some other hospitals that are working together, but their missions are actually different between patient safety and quality. This question is for Ron. One audience member is asking, how are captive insurance companies adapting to emerging trends in healthcare delivery?
And how much time do I have? I think we have a minute and a half. Wow. I would say it could be broken into a couple different categories. One is how to more efficiently cover things like cyber liability, particularly as we move into stage 3 meaningful use, which completely fundamentally changes the cyber liability landscape. Regulatory risk, Medicare, Medicaid fraud and abuse. The risk factors associated with that particular risk are not intuitive. They're not the same as a lot of underwriters are looking at RAC auditors and MIP auditors, and they're going after different things. So there's still a lot of that's an immature environment that I think a lot of big systems are looking at their captives to fund. And they're also preparing to fund more efficiently for provider stop-loss vehicles to actually provide financial protection in some of these risk-bearing arrangements, whether they're clinical bundles, global bundles, et cetera. Lastly would be a good vehicle to, we're talking to several clients about their contemplation of creating warranties around these clinical bundles. So I think that will grow in interest, and we're actually working with some right now on that front.
A lot of challenges. Thank you, Ron. It looks like we come to the conclusion of our 1-hour section. As you are all aware, we are going to continue this lively panel discussion. I would like to thank our panelists right now, because this topic is very much a doom and gloom topic. And I'd like to thank the panelists for keeping the optimism and enthusiasm for the future, because there really are ways that healthcare organizations can thrive within healthcare change. Now, before we conclude, I'd like to go around the table, starting with Dr. Billingham, and ask each panelist to give one takeaway. Specifically, where do you all see the greatest opportunity?
Well, I think we're all striving for efficiency in a healthcare system that really wants to get there. There's a lot of conversations about the economics. There's a lot of conversations about productivity. I guess my parting shot was, when you're engaging in those, don't start with the money dialogue. Start by putting the patient first, and let everything else follow behind that. So I think healthcare is about the patient, so while we're in the process of ferreting through all these challenges, look for the opportunities that improve patient care.
Ron?
I would say probably variations on the same thing. Be open to alternative ways of engaging with that basic care box that I was referring to, that lower acuity, anonymous, consumer-centric population that acute care providers are just not genetically predisposed to marketing to. That landscape will change dramatically. Be open to new ways of accessing those populations. And one other quick point that hasn't actually been mentioned today, and that is, and we see this among very sophisticated providers. And this is it's kind of a random point, but it's an important one. You have to fundamentally understand your cost of care. And there is a lot of ambiguity around exactly what the cost of care is. It's not the charge master. There's a variety of sophisticated ways of assessing your cost of care, but there's a lot of sophisticated providers that don't understand their cost of care. You've got to understand your cost of care.
Agree with that. And Kim?
Don't be afraid to start small. Take it step by step. I think we all wait for the grand scheme. We all wait for the perfect solution, and just don't be afraid to identify your problems and start small.
So we do have additional questions from the audience. I actually want to hear your take on the question that Kim answered earlier too about risk and quality from the physician perspective, having a stake at the table in improving revenue, because oftentimes the lonely risk manager doesn't feel that they're empowered to make an impact on the revenue side, that they're just constantly being reactionary.
Well, I think it's going to be part of the payment structure going forward. I mean, it's as simple as that, is that these quality measures that Kim talked about are going to be embedded, and that, you know, a lot of healthcare systems have a really thin margin, so getting the clinical folks on board to not only accurately measure the ability to have a feedback loop, so you get all this data, what do you do with it? Exactly. I think the issue really is going to be, it's a given that it's going to be part of additional, whether it's pay for performance or, you know, beyond. So I think quality and the avoidance of risk in terms of decreasing loss costs for healthcare institutions. So both patient safety, quality, they've got a seat at the table, and organizations that pay attention to those will definitely increase their revenue.
And I'd like to hear your perspective from the 35,000 foot level regarding risk and quality and your experience from what you've seen.
Yeah, I'm going to take my answer in a bit of a different direction, and it doesn't completely address your question, but it's in the same neighborhood, different block. I would challenge the risk management function within the acute care provider community across the country to be aware of new emerging risks that have operational and financial consequences to them as it relates to these payment transformation models and as it relates to reform in general. I think probably the most missed, yet one of the most significant risks around Medicaid expansion and the expansion of coverage in general is credit risk. It's taking a $60,000, $50,000 employee or family of four who's never had coverage, and they buy a lower metal plan, a bronze plan, and now they have coverage, but they have a $12,000 to $15,000 total out of pocket. What we've there's a piece of coverage expansion that transitions credit risk to our clients. And many of these clients are participating in, payment plans and whatnot and they've drifted into basically the consumer credit world, which has about 12 different statutes that regulates that. And many of them are out of compliance with a lot of those statutes. So that's just one of those unintended consequences of a well-intending, strategy to hopefully increase the wallet size of the consumers. Particularly, there's another hidden risk in this dynamic, and that is within those states that are not accepting Medicaid expansion. So you've got a drawdown in the disproportionate share formula. It can be earned back based on the number of patients that you transition, or the number of citizens in that state that you transition from uninsured to insured. You can earn that disproportionate share back. If you're in a non-Medicaid expansion state, you don't have that ability because you're not transitioning enough bodies. You don't have a vehicle to transition those bodies. So particularly in the states that are not, up to 23 now, that are not accepting the Medicaid expansion, there's some significant financial risk there for the provider community. So there are, in these payment transformation models, there are embedded risks that are not necessarily intuitive.
And I piggyback on Ron's, and change the paradigm a little bit. And I think we're talking about two different things, AR and ERM. And AR, he is exactly right. So you suddenly now, with these high deductible plans, suddenly put medical groups and hospitals in the collection business.
Absolutely.
So now if you have I'll just throw a question out. So now if you have a bad outcome, are you sending grandpa to collections? You know, I mean, and that's not only this credit risk, but it's suddenly understanding people suddenly feel they haven't gone to the doctor for a long time. They do have coverage. They may not fully understand the ramifications of that coverage, and then they get an $800 bill after going to the ER, and they're unhappy. And so I think we've got a ways to go. And I would say that you raised RAC audits, HIPAA, security. I would say that the traditional kernel of clinical risk management, CRM, which is always going to be the kernel, is going to have a layer of ERM or enterprise risk management. And we, as healthcare, leaders and advisors, we have to have conversations not only about the quality of care, the measurement of data, but we need to understand regulatory compliance.
Absolutely.
We need to understand this financial shift in accounts receivable, all of those. So it's financial risk, legal risk, regulatory risk, and clinical risk.
It seems, oh, go ahead.
And operational risk if you don't know your cost of care. I mean, it literally covers all four quadrants. You're right.
I'm going to ask you, Dr. Graham, Dr. Billingham, it seems that we need a little bit more better choreography and coordination with risk management and the activities that are currently going on. Are you currently seeing mergers and acquisitions happen with risk management involvement ahead of time? Or is risk management functioning in a reactionary mode?
I think it's better than it's ever been. We have a ways to go. But I think the chief risk officers of institutions are going to have a seat on the senior management team, and they're going to identify things, and I think the smart C-suites are going to put those risk people to have those conversations. Ron talked about the land grab that's going on, and we've been talking about physician employment and consolidation, and 37% of the audience talking about M&A. I will tell you that when I've spoken to different leadership, I was surprised at the lack of due diligence that was taking place in some of those land grabs, where people were actually going out because the competitor down the street was doing it and saying, boy, if I don't do this, I'm going to do it. So I think it's essential to have the risk people involved early and have a seat at the table.
Thank you. We have 3 experts at our table, so now is really the opportunity for each of you to ask a burning question that you've been wanting to know, to either hear from Ron or Dr. Billingham or Kim.
I actually have one that I've been waiting to ask Kim, and that is, it's having conversations with our clients about the sheer volume of quality measures that they have to keep track of. We have clients that are participating in the Medicare Shared Savings Program, the Bundle Payment for Care Improvement Initiative, the Value-Based Reimbursement Program, and let's throw in the Collaborative Care ACO from Cigna, and then Aetna's ACO model. They could have 150 quality measures that they're trying to track.
Easy.
And do you see a movement? I'm having some interesting conversations with some clinicians about this, but I'm just curious to know what Stanford's view is as it relates to an effort to coalesce some of these quality measures into really meaningful core quality measures that will move the needle the most.
I think it will continue to explode before that happens, because each of the various measures are being driven by different fractions, right? So we've got ambulatory, that most hospitals now are also in the ambulatory business, so they've got to focus on that. We've got inpatient indicators. And as all the specialties become more involved, they're looking at additional, data and information. So
chronic condition quality measures for the Medicare population.
We're starting to see some alignment. So if you look at, especially on the ambulatory side, meaningful use, PQRS, you can actually, but it takes a lot of time, sort through all of those, and you can come up with a core set that will, but that takes time and effort.
And a level of sophistication.
Indeed, and we had people dedicated to actually look into that so that we would minimize the burden of some of the data collection that happens. The other piece that's got to happen is the ability to use our electronic records more effectively to help us on the front end of collecting some of those data. It won't circumvent the need for validation on kind of the back end, but the more that you can align and automate, the better off we're going to be. So,
this is kind of an unfair question, follow-up question, but do you see most EMR platforms being willing to accept workarounds as it relates to PHRs and your way that you're communicating and connecting with the consumer or with the former patient?
You know, I think most of them were started not with none of that in their intent,
in mind,
right? So that was
not
even on their radar. Yeah. If you look at some of the bigger groups, there isn't actually a user group specific to quality reporting. No, but there is one for, you know, finance, there's one, you know. So I do believe that it's starting to happen, but now we're trying to make that happen on the back end. So, you know, and hence the explosion of looking at registries, clinical registries, so that are actually, you know, you're submitting direct to the registry because your EMR doesn't have a spot for that data point to be captured. So, you know, it's still, so I don't know what the answer is. I think it's a work in progress. I think we're going to see more connection from EMRs into registries because it does allow for more longitudinal data collection. And when that, as that continues, I think we'll be a little bit in a better position to automate.
But it does seem like that there's a bit of catch-up right now, particularly as it relates to stage 3.
Without a doubt.
There's a bit of catch-up on those
Without
functionalities.
a doubt, yep.
I have a question for both of you. If you were sitting and listening to this discussion, but you weren't in the cities and you weren't in the suburbs, and you had a 25-bed hospital bed, but you were responsible for a large catchment area and providing care. What are the takeaways that help me navigate if I don't have huge resources, I don't have an IT infrastructure, I'm still trying to implement my electronic healthcare record, and furthermore, I can't get specialty providers? What are some of the solutions for
help?
If you don't mind, I'll go
ahead. I'll see where that takes us.
That's a tough one. That's a tough one.
It is hard.
Two quick points. One, most systems, it's kind of an interesting phenomenon. Most systems are utilization's flat. If they have not embarked on a really serious journey for clinical integration, utilization's flat, but it's spiking in the hub and dropping in the feeders because they're pulling utilization out from the feeders. There are a few exceptions, a few very sophisticated exceptions where they've actually reversed that and are driving utilization out to
pushing
the feeders.
It out.
Yeah. So it really depends on your tertiary care relationships and what it varies by market. But that's critical. What kind of because we've seen some actually I'm segueing into my second point, and that is the very sophisticated telemedicine models right now.
Yep.
That are, so for example, in rural America, I don't think I'm saying anything that's too politically incorrect here, most of our on-call scenarios across the country in rural America are just fundamentally broke. They're broke. Hard to get coverage, hard to get a neurologist to cover 3 rural counties. But we have very sophisticated ways to beam in that neurologist and keep a hospitalist from unnecessarily transferring the patient to that tertiary care facility. I can do a complete neurological exam, or at least 95% of one. I'm not out of my comfort zone. Okay, I don't have to transfer the patient. So we're seeing some pretty sophisticated ways of keeping utilization in those rural environments. But ultimately, and I've had conversations with CEOs of critical access hospitals, ultimately, they better be thinking about an alternative care setting kind of transition, in my opinion.
Yeah, the other thing that I would want to say to that 25-bed hospital is back to my point around the need to have a good management system in place. I mean, even in a place like Stanford, where we have, resources, at our beck and call, we had started with, we owned it as a quality department, collecting all of that information, and we said, this is not going to be sustainable in the long run. So it's pushing it out, again, back to the front line. How do you engage them so that they all become active participants in driving, really the outcomes that you want, and in terms of being able to kind of put some systems where you can collect the data. So that's what I would say, is that you have to look at your operations, and you can't just layer it in. It has to become a part of it.
But if they're not affiliated,
right?
If they're an independent
it's going to be
and
tougher.
don't have that ability, that's tough.
And that's what I think is driving a lot of the growth in collaboratives, where 15 or 10 or 20 can share resources, share education, share data. It's tough. It's going to be tough to do this by yourself.
Yeah.
Vanderbilt's doing a wonderful job of doing that in Tennessee right now, reaching out to the rural facilities, and they're actually pushing utilization out. That's a really interesting model where it's kind of the opposite of of the trend that we're seeing. But it's a challenge. It's a challenge. It's a challenge. And once again, it's a situation that requires the financial metric to be in line with that strategy. And oftentimes, certainly in a fee-for-service platform, it's not. Yeah.
More questions, or Kim? Oh, I have questions then.
Okay, all right.
My question is, do you think someone in healthcare is going to change healthcare? Or is it going to be someone from Silicon Valley, who, these are entrepreneurs who are looking at the current system and saying, I'm an engineer. I'm sure I could assemble all those fragmented pieces together.
Somebody else go first.
Well,
I actually have something to say, but
I've heard the analogy before, well, gee, if McDonald's can get queuing right, why can't we in healthcare systems? And so I think there's some really bright folks that have a way of thinking that looks at, regardless of what the challenge is, healthcare or not, and maybe they're unencumbered by tradition and history and able to jump from point A to point B much more nimbly, is the word I guess we've been using. So I think it'll be a combination, really. It'll be somebody who's taking a look from the outside in, but they're going to want to have conversations with the people who are actually delivering the service to vet it.
Yeah, they have to be part of the team. Yeah. But it really will take a team approach for this. And let's not forget that I think the patient will play an increasingly important role in that design. So as we figure out how to coach patients to manage their wellness or to manage their illness, they're going to be part of the conversation. So
you touched on a really great topic, which is getting patients engaged. So as we mentioned earlier, Walgreens is getting their patients engaged. How are hospitals currently right now getting their patients engaged?
I'll jump in here because I want to make the point that I ceded to Graham. As a rule, not very well. As a rule, not very well. But there are a lot of exceptions to that. But I get back to my earlier analogy of the two axes, in that lower acuity anonymous box, that basic care box. And in my opinion, it will be an entity outside of acute care that really cracks that code. We're starting to see that with Walgreens and CVS right now. The Walmart is going to be getting into that space in a very big way. They're dipping their toe in right now, but all signs seem to indicate that them and Target will do the same thing. I think that considering that 51% of all the ACOs are physician-led, I think that a combination of primary care assets with an innovator, a disruptor, is a very, very powerful combination. And if acute care doesn't figure out the patient engagement conundrum, they could find themselves being subcontracted to for the ER and the OR. That's my concern for our client base, is they've got to get into the patient engagement world in a big way.
And that doesn't mean just social media.
That is not social media.
It means really engaging them.
Yeah, absolutely.
It's interesting that we haven't been able to do that thus far.
Well, they haven't been incentivized to. You know, and they're, the way that they've been paid, it was in pursuit of a completely different model. But when you think about it, I still go into this, I feel like a relic going into a store and buying a CD now. I mean, and that didn't take that long.
Yeah, it didn't.
I have friends that say, I can't believe you still have CDs. Yeah. So you know, there's some highly disruptive opportunities out there in healthcare.
Well, I'm looking forward to hearing about more disruption, but we've come to the close of our presentation. For those of you who stayed on the call, please use your resources tab to go ahead and submit a survey. Again, I'd like to thank the entire expert panel, Kim Pardini-Kiley, Ron Calhoun, and Dr. Graham Billingham, for joining us for this very complex topic that we can go on talking on for hours, perhaps over a glass of wine. Thank you very much for attending. And thank you to our partners, Aon Risk Solutions and the Medical Protective Company.